Hello, all of you on YouTube get the seamless experience that those of you who are joining us live do not and get to experience the ups and downs of our technological difficulties. Welcome, everybody. Happy Thursday. I'm very, very excited to tell you about two people who will be sharing the stage that you will see, but I first wanted to give a big shout out to the folks behind the scenes who are making this happen. First off, with our scribe, Harry, I'll ask you to pop in, tell people a little about yourself and say hi.
Hi, everyone. My name is Harry. I'm a third year resident at UCSF. Um, Excited to be here early at 6 a.m. and it's good to see you all.
Uh, Unlike many people who I get to meet virtually, Harry is somebody who I bump into in real life a lot, and I appreciate you also being wide awake at 6 a.m. to describe it. Appreciate it, Harry. And Julia is doing the teaching points today. Julia, do you want to say hi?
Sure. Hello, everyone. My name is Julia. I just completed med school in Germany, and I'm about to start my internship soon.
And crushing her thesis at the same time and still making time to do teaching points. Thank you, Julia. I said I haven't had the privilege of meeting most of the CPU Solvers Academy members in real life, but our case discussant today is another exception. I've been really excited for today because I met Sohil actually when we worked together, taking care of patients together on the inpatient wards at the San Francisco VA. And gosh, it was very, very clear that behind this man is a tremendous amount of enthusiasm and fire. And it kind of coalesced when he shared his love for aviation and how he always likes to make it into the sky. And I think clinically, that's what I've seen him do. I've seen him start off as a beginning MS4 and now just absolutely skyrocketing clinically. So Sohail, I imagine you're a little bit nervous today, given it's your first discussion, but tell us a little bit about how you're feeling.
Yeah, I know. Thank you, Rabih. Good times in the San Francisco VA. And like every day was like a mini clinical problem solving session. This was in person too. So it was such fun times at the San Francisco VA. Totally miss those days. But um I am feeling nervous but excited to be co-discussing with Rabih today. And can't wait to get started. And I'm really grateful for the community here who has supported me for the 8 or so months I've been here on the clinical problem solvers team. And yeah, I'm really grateful, really appreciative. Thank you, everyone, and thank you for this opportunity.
Oh, we're super, super excited. And you're way more organized than I am. It seems like you've made your bed at 6 a.m. in the morning. So kudos to kudos to you. I also want to welcome our case presenter, Hans, who's coming back for, I think, your second or third case. I can't quite
Yeah,
remember.
this is my second case.
Second case. Welcome back. Update us. Well, actually, maybe you can remind people a little bit about yourself and then update us about what you've been up to.
Oh, sure. I'm Hans Del Mundo. I'm a general physician from the Philippines. I actually began my medical career as a general surgery resident at the Philippine General Hospital. However, due to the pandemic's impact on our training, I shifted to primary care. So I have now embarked on transitioning my medical career to the United States, where I aspire to develop my knowledge and skills as an IM resident. And while taking my USMLE steps last year, I also gained inpatient clinical experience at Inspira Medical Center, Vineland in New Jersey. And this year, I participated in an intensive preceptorship program at the Primary Care Clinic of Hawaii, which is where I encountered this case I'm about to present.
Oh, cool. Wow, that's crazy. You've been to Jersey and Hawaii. You basically sampled
Yeah.
the entire spectrum of the United States. That's awesome. Well, we're so, so happy to have you here. And we'll chat a little bit more about your experience, but maybe just for the sake of time, we can jump into the case. So
Yeah.
I'll ask you to jump into the first aliquot, and Harry can feel free to
Okay.
share your screen.
Okay. So again, thank you for the opportunity to present another case. This is the case of a 71-year-old male who presented to the ED with sudden onset, dull abdominal pain. For the history of present illness, 2 weeks prior to consult, the patient had diarrhea, but no consultations were done. And on the day of the consult, patient had sudden onset abdominal pain, rated 6 to 7 out of 10 in severity, and was poorly localized with no specific triggers. and his last bowel movement and flatus was yesterday, but he denies nausea, vomiting, no fever or chills, no hematochezia or melena, no weight loss, chest pain, or dyspnea. I'll stop there for the discussion.
Oh, superb. That's so cool. Sohail, I'm curious. You have two pieces of information now. You have diarrhea and you have abdominal pain. I'm curious, before you tell us what you're thinking, I'm really curious to try to tease out where you're starting. Or is your mind inclined to start with diarrhea or start with abdominal pain?
Ooh, okay. So these are two separate chief concerns here. And on the wards, I have seen a lot of abdominal pain, and it has been sort of deceiving in where it is located. This patient does not have a area that he's pointing to, but it's sort of dull abdominal pain. But we create this schema and we nicely divide the abdomen into 4 compartments or so. I found that totally deceiving, and I've had patients that had right abdominal pain, and they had pathology in the left side and vice versa. So the abdominal pain is something that is in the back of my mind. I am more inclined to start with the diarrhea, but I'll get back to the abdominal pain. But the diarrhea is like 2 weeks, and I think 14 days is a cutoff for when we would classify diarrhea as acute versus subacute and chronic. And this patient is right on the borderline. But diarrhea and abdominal pain go hand in hand. So I'm actually worried that the patient has sudden onset abdominal pain that has gone.
Yeah.
I think this he has been chronically having abdominal pain, and suddenly so what is the cause of sudden onset abdominal pain? The things I want to rule out are like an acute abdomen, so there's any rebound tenderness, and sometimes a cardiovascular manifestations can present with an atypical sort of abdominal pain. It's very kind of unusual that there's no nausea and vomiting. No fever is kind of makes me less concerned for an infection. Although not ruled out as of yet. No hematochezia. I guess that's a good negative footnote red flag, which I'll keep at the back of my mind. But yeah, these are my thoughts.
Yeah, I think it's always a little bit intense to try to figure out what to focus on initially. And I think that the problem with both abdominal pain and diarrhea is that their ability to plot out a simple, clear-cut path is pretty limited. And so I think you have to sit there and step back and try to see how you can use the unique aspects of this case to make progress. And I think one thing that you latched onto is that the abdominal pain was sudden in onset. And I think that's really, really important to latch onto, because whenever something is sudden in onset, it often means that either something blocked or something ruptured. And I think that's really true of the belly. When you think about sudden onset abdominal pain, you think, oh, did this person have obstruction of their biliary duct from cholecystitis? Or does this person have a perforation of a peptic ulcer? And I think those are two things that we have to think is what is blocked or what is obstructed, or what is blocked or what is perforated. And so I think that the question that we're trying to answer right now is what organ is on the hook for these symptoms. And I think when you think of diarrhea and you merge that with abdominal pain, you become tempted to say, well, there are many things in the abdomen, but the presence of diarrhea makes me localize the problem to the intestines. And I think there's another clue that the localization is intestinal in nature here, and that's that the pain is diffuse throughout the abdomen. Because if you ask yourself, Sohail, what structure is found diffusely in the abdomen? It's the bowel. And it's most of the time, most people with poorly localizing pain have disease of the intestine. And so I think the fundamental question that we're trying to answer here is how confident are we that this localization is actually an acute intestinal issue, And I would say the combination of preceding diarrhea followed by the abrupt onset of diffuse abdominal pain has a moderate to high localization to the intestines. And so this becomes really a question of, well, what kinds of diseases affect the intestine? And I think you've already said them. You can get infection of the intestine. You can get perforation of the intestine. You can get obstruction of the intestine. As the leading considerations, and some other things can happen as well. I'll just install one caveat, and maybe we can have it as a dialogue. So Sohil, I'm curious, when you've seen patients with diarrhea, have you had any mimickers of diarrhea show up and mislead you or fool you in clinical life when a patient says they have diarrhea, but they actually turn out to have something else?
Kind of think. So I guess one of the things that I've seen is sometimes there's a blockage, and then
Yeah,
like the patient is constipated.
exactly.
There's like a obstruction there, and
Yeah.
then there's a whole bunch of stool in the back that's like sort of obstructed.
Exactly.
We treat the constipation, poof, everything goes.
Exactly. Nailed it. So hold that thought, right? So I think we have a decent case that this is an acute bowel issue. Of the things that we worry about the most, ischemia, perforation, or obstruction, obstruction is by far and away the most common cause. Bowel obstruction is much more common than bowel perforation, is much more common than bowel ischemia. And so if we prioritize obstruction, and then you have this 2 weeks of diarrhea, part of you has to wonder, wait, is that actually diarrhea? Or was that a clue that the patient actually was partially obstructed, having overflow incontinence or overflow diarrhea, and then this is an extension of that? So in my mind, I'm wondering if the diarrhea is infectious and the patient had a perforation, but I'm also wondering, was this pseudo diarrhea and the patient was partially obstructed and then went on to a full obstruction? But my biggest piece of advice, Sohil, is diffuse abdominal pain, often a bowel problem. What bowel problems? Ischemia, infection, perforation, obstruction. And I think that's probably going to be our working hypotheses until we get more, but let's get more from Hans.
Okay, so for the past medical history, the patient has type 2 diabetes mellitus, hypertension, paroxysmal AFib, benign prostatic hypertrophy, and history of kidney stones, where he underwent lithotripsy before. For his medications, he's taking metformin 500 milligrams BID, metoprolol succinate 50 milligrams daily, tamsulosin 0.4 milligrams daily, warfarin 5 milligrams, 1 tablet daily during weekdays and 2 tabs daily during weekends, allegedly with good compliance or with the family history of type 2 DM also and heart disease. For social history, he is originally from the Philippines, moved to Alaska in the 80s, and recently moved to Hawaii in February this year with a 6-month supply of his medications. But prior to the ED consult, the patient just returned from a 2-week trip from the Philippines, but was last seen by his PCP more than 3 months ago. He is never a smoker, occasional drinker, denies illicit drug use with no abnormal activity or new food, allergy to hydrocodone. For his vital signs, his BP is slightly elevated, 142/78, heart rate of 76, slight tachypneic at 25, temperature 37.1, O2 sat of 95%, and a BMI of 31.24. For the physical exam, he's lying in bed, not in acute distress, alert and cooperative. The rest of the physical exam is unremarkable except for the abdominal PE, which showed a soft distended abdomen with mild tenderness to palpation in all quadrants, but no rebound tenderness, no guarding, no palpable masses. DRE showed good sphincteric tone. The prostate was not enlarged, no palpable masses or fissures, and no blood for examining finger. I'll stop there for the discussion.
Oh my gosh, I know, Hans, you're making your career pivot to internal medicine, but you present with the precision and velocity of a general surgeon still in your heart, my friend. That was awesome. I think Harry's wide awake now, having to keep up with your excellent presentation. Thank you. This is a very, very well presented abdominal case. I really appreciate all the context you've given us and the excellent exam. So if we just actually focus on the background information, so let's put pause on the exam and the vitals. What were you thinking, and what thoughts came to your mind as you were hearing the medical history?
Yeah, so I have a couple of thoughts. So first is the history of metabolic syndrome, and especially the paroxysmal AFib. And the reason I goes there is because that can pretty much like shoot embolic in the vasculature, um, causing like things like acute mesenteric ischemia type of picture. And it's the patient has sudden onset abdominal pain. And I know we discussed, sort of this vascular causes of intestinal pathology, and acute mesenteric ischemia would be a little bit higher on my differential. The patient is on warfarin. I'm not sure if, if if the patient is taking that properly. I assume so. But even I've seen patients who are even on warfarin, therapeutic warfarin, and still have clots in their left atrium. There are breakthrough clots, and it's not out of the realm of possibilities here. Um, and then the other thing is the social history is really interesting. And at first I was like, Hawaii could be leptospirosis, but on physical exam, there's no like jaundice or anything like that. But I kind of want to keep my infections lower on the differential just because of the vital signs. But and jumping into the vital signs, the temperature is afebrile, I believe. The blood pressure is a little bit high, so unremarkable vital signs. The abdominal exam is interesting because it shows like it's just mildly unremarkable, and it's mild, and it's there's not much going on there except for the mild tenderness to palpation. So I'm thinking, is this like pain out of proportion to physical exam is what I'm thinking. Like, could it be like an acute mesenteric ischemia? Reassuring that there are no red flags. So my threshold for perforations are a little bit lower. And obstructions, we talked about obstructions. I've seen obstructions on a whole wide spectrum from, patients just feel mild discomfort to like really, really bad pain. So I think that's still high in the difference.
Oh, those are absolutely superb thoughts, my friend. I have nothing to add to your thinking, and we'll just move the conversation along by proposing what I would do next. I think we probably in real life overthink patients with abdominal pain as we try to make progress on what they could have, when the truth is that one test answers most cases with relative ease, and that's a CT scan with contrast. So if you're operating at Sohil's level, where you already have really strong knowledge about all the disease entities, in real life, it becomes a question of who do you scan and who do you not scan. And so the approach to abdominal pain in the emergency room or urgent care, or even if a patient develops on the ward, is very similar to the approach to headaches and the approach to back pain. And the patient with the headache, it's a question of who do I need to get a CT or MRI? And the patient with back pain, it's the same. And so developing a robust approach to alarm signs and symptoms with abdominal pain is really important. And anytime anybody has acute, hyperacute onset abdominal pain, that is a severe alarm symptom that crosses the threshold for imaging. So the moment this patient shared this history with us, it was very, very clear that the most efficient pathway to diagnostic clarity is through a CT scan. And so the question becomes, once you have this alarm sign and you know you're going to get imaging, is there any other thing that you should get in addition to clues that will really, really support or maybe obviate the need for a CT scan. And so we get labs in this patient to help us understand and decorate the results of the CT scan, not to refine them. The only way the laboratory results will obviate the need for a CT scan is if the patient has a positive lipase, which would be consistent with pancreatitis. But in truth, most patients with pancreatitis who do not drink alcohol need a CT scan to understand why they got pancreatitis in the first place, i.e., do they have an obstructing gallstone or do they have a pancreatic tumor, as an example. So remember, the approach to abdominal pain in real life is all about, does this patient have alarm features or not? And if they do, they need a CT scan, unless they have alcohol use and a high lipase. But there are also, in addition to the labs, 2 other very key tests to obtain in patients with abdominal pain. And Sohil mentioned one of them, and that's an EKG. Because if this turns out to be an inferior wall myocardial infarction, you definitely don't need a CT scan. You also definitely don't need a CT scan if your patient has urinary retention. And so a 71-year-old man with a history of BPH who develops abrupt onset abdominal pain, I think getting a post-void residual is really, really important. So what would I do in real life? I would get an EKG and I would get a post-void residual. If those were not explanatory, then I would order the labs, but I would already order the CT abdomen pelvis with contrast. It's really, really important to, whenever you're suspicious of acute mesenteric ischemia, as Sohil outlined, that you put that in your radiological concern. The reason for that is that while there are very obvious signs of acute ischemia on CT scan as it affects the gut, with diffuse gut wall edema and even sometimes ileus, it's sometimes very, very subtle to appreciate the small lesions in the vasculature perfusing the bowel. And so if you do not tell your radiologist that you're worried about ischemia, they may notice the bowel findings of edema and dilation and misascribe those findings to obstruction or infection, when the process is a tiny lesion in the vessels that may be subtle or overappreciated. And we've had a couple of cases of VMR that illustrated this point before. So in real life, Sohil, after sharing the thoughts that I had with you, EKG, post-void residual, labs, CT scan, specifically mention your concern about acute mesenteric ischemia. I think the INR is going to be illuminating here. If this patient is sub or supratherapeutic, that'll be a nice way to decorate this case to see what clues it gives us, as intra-abdominal hemorrhage is also possible in addition to ischemia. Hans, I recognize that different places do things differently, so your approach may be very different, and I would be curious to learn from it. But actually, before you tell us the next aliquot, I was really curious to ask you what it was like to meet and care for a fellow Filipino in a foreign land. What was that? Did you all connect over that, or how did that go?
Actually, I met this patient in the clinic
Oh, I
during
see.
hospital follow-up.
I see.
So I only helped manage him after he was discharged from the
I see.
hospital. And it was
Gotcha.
nice also having a Filipino patient in Hawaii.
Amazing. Amazing. Well, thank you for that. I appreciate it. And thank you then, even more gratitude for you sharing this case with us, especially since you had to put it together in retrospect. So that was really nice of you. All right, why don't you give us your next aliquot?
Okay, a great discussion, by the way. So for the labs, his CBC revealed WBC of 10.2, hemoglobin of 11.7, hematocrit of 35.6, platelet count of 205. For his CMP, sodium electrolytes was normal, glucose was slightly elevated at 144, creatinine was normal at 0.9, the AST/ALT was also normal, 26-29 respectively. The alkaline phosphatase was 67, which is normal. Normal bilirubins also. Amylase and lipase were normal, but the INR was more than 9. Urinalysis revealed a trace protein, RBC 0 to 5, WBC 0 to 5, with negative leukocyte esterase and nitrite. FOBT was positive, and EKG revealed normal sinus rhythm. The chest X-ray showed no acute finding, with only borderline cardiomegaly, mildly atherosclerotic tortuous thoracic aorta, and the abdominal X-ray revealed mild small bowel gas distension up to 3 to 4 centimeters. I will stop there for the discussion.
Wow, that's so intriguing. All right, Sohail, what are you thinking?
All right, so these are really in general very unremarkable labs, except the INR, which I will get to you. But like the white blood cell count is, I think that's normal, maybe borderline normal high kind of thing. But I wouldn't take too much stock into that. The hemoglobin is low, but is not the transfusion threshold. So I will just, I will keep that in the back of my mind. And the platelets are, sort of unremarkable here. The electrolytes are unremarkable, and we were pondering the possibility, Rabih, of of sort of a urinary retention type picture, but like the renal labs for me are normal. So I don't know if I think like less suspicious of a post-renal type of picture here. And the lipase and amylase are also normal, which is great. So less concerned for a pancreatic pathology. The liver labs are normal, so less concerned for a biliary gallbladder type of pathology as well. But the INR is elevated, and you mentioned, Rabih, earlier in the talk about a concern for hemorrhage, which this could likely be, especially in conjunction with the low hemoglobin. And I'm not sure. So the next question is, where is the hemorrhage localized to? Like where along the intestinal tract is that happening? The patient did not have hematochezia, so I'm a little bit so it could be, it's probably not in the intestines itself, although there could be a low trickling blood, and it can cause like sort of a cold blood on the stool if you really test for it. Oh, it is positive. Okay. I just saw that. So I think there's some sort of hemorrhage bleeding going on, some slow bleeding going on somewhere in the intestine. And then the imaging is the chest x-ray, the atherosclerotic aorta, probably saw some calcifications there, which is really common in elderly patients. And then the abdomen is mildly bowel distension up to 3 to 4 centimeters. So, could this be distension? Always rings a bell of like obstruction, like a pseudo obstruction type of picture, which could be going on in conjunction with the slow bleeding, especially due to like the edema and things like that. But yeah, those are my thoughts. But
yeah, you're so good. It's absolutely spot on. Just I actually wanted to do a little bit of a side chat and ask you authentically, how are your nerves now? Curious. Compared to before. What's that?
A little better.
Yeah, I mean, you feel like you're cruising. I think these analyses are absolutely spot on. So Sohail, this is a really, really fun conversation that I get to have with you now, because I promise you I get to have it with every intern. And if my hopes and dreams come true, we'll get to work together next year when you're an intern too. But so an FOBT, hear me out, okay? In order for me to really, really explain the value of an FOBT, I need to take you to a different place, and that place is the urine. Okay, so if you're trying to establish whether somebody is bleeding or not, and you're trying to establish if the source of their bleeding is the urine, and they urinate, and you don't see any blood with your own naked eye, but the lab calls you and says, hey, there's blood under the microscope, i.e. there's a microscopic amount of blood. Do you think the patient is having acute bleeding from the urinary tract?
No, because it's not that much in the moment.
Exactly, right? So what is a fecal occult blood test? It's the same concept. You look, the patient looks, there's no blood coming from their stool. But if we put it under the microscope, we see a microscopic amount of blood. But that's not what we're asking. We're asking, is the patient having an overt macroscopic bleed? So a fecal occult blood is telling you if there's a microscopic amount of bleeding in the GI tract. So if your patient's FOBT is positive, the only conclusion that you can come to is that the patient is having a microscopic amount of bleeding in their GI tract. But when the patient is presenting to the emergency room where the question is they're having an acute macroscopic bleed, the presence of microscopic bleed does nothing but distract you. And that's why your best friends, the GI docs who you spent a whole month with, will be very, very perturbed if you call them and say, I'm worried that this patient is having a massive GI bleed, and I need you to use an invasive procedure with a camera to look for it. And they're like, yeah, sure, absolutely, we'll be right there. What's your evidence? And then your answer is, oh, I see a microscopic amount of bleeding on the fecal occult blood card.
I'll still manage a way to do that, Rabih.
Probably. You know, there's very few ways to make sure your GI colleagues are always happy at all times. I say that with Jess because I love them all. They're right. If we think it through, if all you have, the only case you have for a macroscopic, significant GI bleed is a little bit of blood on the fecal occult blood card, it's no different than if a patient, than you telling a patient they're gushing out of their urinary tract when their UA is positive for blood, but you cannot see it in their urine with your own eyes. So here, the pre-test probability of a fecal occult blood being positive in this patient is through the roof, because almost all people with warfarin will have a small amount of bleeding in their GI tract for their life. So this finding is of no significance at this time, and we have to wait to see if the patient has macroscopic evidence of blood loss with our own eyes. And that could be true, but the fecal occult blood test does not allow you to predict that at all. A negative fecal occult blood test means the patient is not having microscopic bleeding, but they could open up 2 hours from now. And so I would actually follow our GI colleagues' instructions. And I don't remember the last time I did a fecal occult blood test for that reason. Because what you're really saying is there microscopic bleeding? And the answer to that is that's not a relevant question to ask at this time. What is very, very relevant is to say, oh my gosh, I'm really worried that this patient is bleeding somewhere because their INR is very, very high. And we've already articulated, Sohil, why we're worried about the bleeding being intestinal in nature because of the symptoms the patient is having. But now we have to pause and say, oh, wait, how confident are we that this person is having intestinal symptoms? And I'd say the answer is pretty high. But are there other places the patient can bleed in the abdomen that we may not know? And I think that's where you have to expand the spotlight to say, is this person having an intra-abdominal hemorrhage outside the GI tract, i.e. in the intraperitoneum or retroperitoneum, that is causing paralytic ileus of the bowel, which is an unfortunate but well-described consequence. So it could be very true that there's blood around the bowel on the outside, retroperitoneally or intraperitoneally, that's causing the bowel to go, ooh. So I think that would be my leading concern right now. Paradoxically, though, Sohil, we have to talk about the possibility of clot here. And in order to understand why the patient might be hypercoagulable right now, I just got to ask you one question. Do you remember, Sohil, the concept of cubital skin necrosis? Does that ring a bell from step studying?
Yeah, it's like a warfarin type of side effect. I think.
Exactly. Exactly. So the reason you necrose your skin is because you have ischemia to your skin. And you have to stop and be like, wait, what? Why would warfarin cause ischemia? And I'll explain that. So in addition to lowering factor 7, which causes the super high INR, warfarin also eliminates protein C and protein S. Deficiencies in protein C and protein S causes patients to be thrombogenic. So Sohil, when somebody's INR is this high, you know their factor 7 is very low and therefore they're at high risk of bleeding. But their protein C and protein S are also super low because of the same effects of warfarin. And so these patients, just like patients with DIC, are hypercoagulable and hypocoagulable. So your pretest probability of acute mesenteric ischemia has not been taken off the table by the presence of an INR that high, because the only thing that a high INR does, a super high INR, is it opens the door to bleeding, but does not close it shut for thrombosis. So I'll summarize. Fecal occult blood test, it belongs in the world of screening for GI tumors, not in the world of acute medicine. It's a great test in that space, but not here. A high INR is the patient bleeding inside their bowel, not yet. Outside their bowel, possibly. And then finally, thrombosis still on the hook. One very rare but really important thing to entertain, Sohil, is the patient is bleeding not outside their bowel, not inside their bowel, but in their bowel wall. And that's called an intramural hematoma, where the bleeding is actually contained in the wall, so it doesn't go out and doesn't go in. Causes really bad abdominal pain, and it does not deflect the hemoglobin because the amount of bleeding is very minimal. So my CT scan request now will be, does this patient have acute mesenteric ischemia? Does this patient have intra or retroperitoneal hemorrhage? Or, these astute radiologists, can you look closely at the bowel wall for an intramural hematoma, a hematoma in the bowel wall? That was a lot. I'm curious what thoughts, clarifying questions you have of this before we hear from Hans.
No, it makes total sense. Thank you so much for elucidating on that test over there.
Yeah, you got it.
As the bugger. But no, like, really separating out what is put in here, I think is the key. And, as is with all, with everything in medicine. And I'm really glad that you highlighted that, as well as the different sources of, bleed for this patient. So it could be within the ball, it could be contained, or it could be like a hypercoagulable state.
You always summarize like a sponge. I love it. All righty. Hans, we have us on the edge of our seats. What did you have next?
Great insights, everyone. We were actually also wondering why they ordered FOBT during his admission. So, anyways, for the next aliquot, CT scan of the abdomen showed small non-obstructing stones of the lower left kidney pole with moderate colon diverticulosis. There's a circumferential rectal wall thickening with stranding of the rectal fat. Mild small bowel dilatation with zone of transition at the mid-lower abdomen at the site of focal segmental marked small bowel thickening with fecalization of the small bowel proximal to dislocation, which suggests partial small bowel obstruction. The CT angio of the abdomen and pelvis showed unremarkable arterial system in the abdomen and pelvis, no thrombus or occlusion in the mesenteric arteries. So surgery was consulted, and the plan was for exploratory laparotomy, and they started the patient with IV ciprofloxacin and metronidazole for antibiotic prophylaxis. So I will stop here, and the next aliquot will reveal the final diagnosis.
Thank you so much, Hans. I really, really appreciate it. So Sohil, I'd love for you, before you take us to what you're thinking, to sort of summarize where you think the problem is now, because we got the CT scan, right? So what would be your updated problem representation now that you have the information that we've been itching for?
So I think probably like a 70-year-old male, history of paroxysmal AFib, diabetes, on supratherapeutic warfarin, here for here presenting with sudden onset abdominal pain, CT abdomen showing is that intestinal small bowel thickening, suggestive of partial SBO, and rectal wall thickening. I'm not really sure. Like I've seen thickening before, and it's very non-specific. I don't know if this is due to like thickening in general just means inflammation, and it could be infection in origin, it could be autoimmune in origin, it could be malignancy in origin, it could be edema, it could be a variety of causes. So while the CT scan shows rectal wall thickening, I'm still unclear as to the cause of this. Maybe you can help me out, Robbie, but yeah, the etiology is not something that I'm so sure about, but I do know that there's this focal area, the transition point, is suggestive of SBO, which we were initially suspicious about. And then the acute mesenteric ischemia is ruled out based on the no thrombus exclusion. But I would be concerned for sort of if I had to put my money on one thing, maybe a malignancy in this really old, really elderly patient here. But I'm not sure if malignancy presents with sudden onset abdominal pain, but I guess it could in the setting of inflammation.
Absolutely superb. So I completely agree with you. I think to sort of take the loop to sort of go back to the original concern of diarrhea, I think when you have rectal wall thickening and this degree of fecalization of the small bowel, which means that there's been so much stasis that the small bowel is full of stool, I start to wonder whether the patient actually had a diarrhea or actually was very constipated and was having overflow diarrhea. But I would talk to the radiologist about how much fecalization of the small bowel there was. So I think you're right that the finding that we have now is really about what causes the bowel wall to be thickened. And you're right, the most common cause for bowel wall thickening is inflammation. And that inflammation can be infectious or inflammatory. And the infections are, the diarrheal illnesses, the inflammatory diseases are either inflammatory bowel disease or diverticulitis. So when you ask me, when I see bowel wall thickening in the emergency room, it's either an infection, IBD flare, or diverticulitis. But as we talked about, you can also get bowel wall thickening from ischemia, and that ischemia triggers an inflammatory reaction. If you think about ischemia on the skin and think about what that does and the gangrene and the inflammatory changes that happen. So inflammation or ischemia are the most important causes to think about. Those cause bowel wall edema. The term angioedema refers to the development of edema without inflammation. And that is a consideration in some patients who have bowel wall thickening, whether they have GI angioedema. And so in a patient who's hypertensive, you always want to make sure, are they on an ACE inhibitor? And is the ACE inhibitor causing bowel wall angioedema? So I briefly looked and saw he's not on an ACE, so I don't think he has angioedema. So if we go through the common list of inflammation or angioedema, could he have IBD? Unlikely. We have no symptoms to suggest that. Could he have an infection? Very possibly. He had diarrhea. Could he have diverticulitis? It's possible. You can get small bowel diverticulosis and therefore diverticulitis. So I think a diverticulitis is possible, infection is possible, ischemia has been ruled out, and IBD has been ruled out. So those are all causes of what the bowel wall being edematous, either from inflammation, ischemia, or from angioedema. But the bowel wall may be thickened not because of edema, but because of malignant infiltration, which you said already. Malignant infiltration is usually localized to a specific distribution, and the fact that it's in such an extensive area of the small bowel makes it a little bit less likely. And then finally, bowel wall thickening could be because the bowel is full of blood, i.e. the person has an intramural hematoma. Sometimes the CT can help you distinguish that, but sometimes you need pathology to do so. So the way I'm putting this case together is, did this person have either small bowel diverticulosis or an infection? Did that alter his gut motility and alter his vitamin K producing gut bacteria? And that's why his INR is high as a consequence of that? Or is the high INR causing this problem of an intramural hematoma? So I think ultimately pathology and resection of the bowel will help us understand what's there. Is it diverticulosis? Is it an infection? Or is it blood? And I think those are the three considerations to have. It's unfortunate that this patient has progressed to such a high severity to need that, but I do think that that will reveal the answer ultimately. Any questions about any of that, Sohil?
No. I guess my one question was, would you still be concerned for diverticulitis in the setting of no infection or no, like the patient's afebrile, or have you seen diverticulitis in the setting of non-inflammatory markers?
Diverticulitis, like cellulitis, the vast majority of patients are afebrile unless they developed a complication. So yeah, the inflammatory signature of diverticulitis is usually limited to the fat around the diverticula, i.e. there's fat stranding, but it rarely makes it systemically. So most people are afebrile. A large minority of people have a leukocytosis, but we diagnose diverticulitis all the time with just inflammation on CT scan with no blood fingerprints on the white count or the fever. Yeah.
Thank you.
For sure. All right, Hans, what did you get?
Okay, for the final aliquot. So prior to surgery, warfarin and metformin were held, and the rest of his medications were continued. He was actually transfused FFP, IV vitamin K to reverse warfarin, and the exploratory laparotomy was done with small bowel resection of the segment with intramural hematoma, which was the cause of the small bowel obstruction. The pathology revealed small bowel with ischemic changes and hemorrhage with periintestinal fat necrosis. No malignancy was identified, and the patient was discharged on Eliquis, acetaminophen, and the rest of his maintenance medications. So for the final diagnosis is small bowel obstruction from intramural hematoma secondary to supratherapeutic INR.
This was an incredibly educational case for so many reasons. I would say that you allowed us to talk about how we localize the syndrome to the gut in the first aliquot, and then you told us how anticoagulation can complicate the picture. And I think from there on, it just really, really sequentially presented the data so that we can walk closer and closer to the final diagnosis. That was awesome. I'm curious, what was it like for you to take care of this patient after their event, but reflect on this diagnosis? What did you learn from the journey?
Yeah, so this was actually a very good case for me. I was surprised when I saw this patient. This experience underscored the importance of regular follow-up with the primary care physician, because had the patient maintained a regular contact with the INR monitoring and adjustments to his warfarin, this complication could have been prevented. And it highlighted the critical role of continuity of care in managing chronic conditions like this effectively and preventing serious outcomes.
Every time you've been here, Hans, you've been so eloquent, so poised, and have brought such incredible cases. So my own wishes and dreams would be to see you here much more frequently than you're able to join now. So hopefully we'll see you next time with another really, really cool case. Thank you for another awesome learning experience.
Thank you also.
Sohil, how did it feel?
No, it was a really interesting case. Thank you so much, Hans. I learned a lot. I'm learning more on the GI side, even though 1 month is not enough for to learn the entire GI diseases. But no, I learned a lot. What was striking to me was it's very deceiving how a pathology in the rectum can be eventually found in the small bowel. And I think that's just the way how the small bowel and the large bowel are sort of connected, sort of windy. And so, you know, uh, you can easily have pathology in one side, and then just due to the proximity have it elsewhere too, even though it's you see it on the large bowel. But lesion is in the small bowel. But yeah, thank you so much. This was really fun.
Yeah, I thought you were cool, calm, collected, and on the money at every point. From aliquot 1, where you were like, what's going on in the GI tract, to aliquot 2, latching on bleeding, and thrombosis, and then I think getting to learn about a new entity of an intramural hematoma. And if I were to try to explain my best guess, just remember that the patient has a risk of bleeding everywhere in their GI tract. So if I were to actually guess what's going on in the bowel, in the small bowel versus the rectum, is that the rectum has the same problem that's actually there in the small bowel, that there's intramural hematoma everywhere. But remember, the colonic wall is much thicker than the small bowel wall, and therefore is a much more ability to tolerate blood than the small bowel. So I think the small bowel, unfortunately, got compromised because of its size. And so I suspect that the same thing happened in the colon that happened in the bowel, but the difference is that the colon can absorb that and tolerate that without getting obstructed as compared to the small bowel. So I would imagine that on follow-up imaging, if you were to get it, that you would see resolution of the rectal wall thickening with normalization of the INR. The same process is affecting the small and large bowel, but I think the large bowel has the capacity to be able to tolerate it much more so than the small bowel is what I would suspect. But it was so cool to get to do this with you. I'm glad it was a lot of internal medicine bread and butter, but I'm also really glad that we got to talk about something not so common at the end. So thank you both to you, Sohil, and to you, Hans, for such an awesome hour. I appreciate it. All right, Julia, we'll hand the mic to you for the teaching points.
Thank you so much. First, thank you, Sohil. I'm really amazed how you can present the thoughts so like grateful, and everyone. It was very easy to follow what you were thinking, and I've learned a lot, and that was a great case, Hans. Thank you. So I'll try to summarize my takeaway points for today. And first, we had this patient, the 71-year-old male, and he presented with the two main symptoms, the abdominal pain and diarrhea. And we first tried to focus and decide where we want to start to get our heads on. And the most distinct factor was actually the sudden onset of the abdominal pain. And that's why we kind of thought, well, how can we use that feature for our localization? And if we have a sudden onset, we should think about like a blockage or rupture. And the diarrhea got us a clue, as well as the diffuse or polylocalized pain that we are dealing with an acute intestinal syndrome. And when we have a patient with an acute abdominal pain, the mnemonic VIPO can help us. And what I also learned today is that obstruction is very common, so we should definitely think about the obstruction a little bit more than like a perforation issue, for example. And an obstruction that can also lead to pseudo-diarrhea, for example, in overflow incontinence, which can also be when we have a lot of fecal like residuals in the CT scan, like in our patient. And then in the emergency room, we really want to know which patient we would like to scan and which not. And Rabih told us that we should definitely look for alarm signs. If they're present, the patient gets a CT scan. But also it's important not to forget to perform an EKG. Are there any signs for a coronary or infarction? If we have signs for urinary retention, and check the labs. For example, if we have like a patient with a history of alcohol abuse and high lipase, that would be a scenario where we wouldn't need to scan the patient. Then another clue, which is just very handy to know, is that if you think about acute mesenteric ischemia, like in our patient, we should really mention that to our radiologist friend, so they know what to look for, because changes can be very subtle. Also check the lactate for ischemia. Our patient had an elevated INR and low hemoglobin, so that can be a sign of intra-abdominal hemorrhage. But it's important to remember that intra-abdominal hemorrhage can be intra and extra-intestinal and also in the gut wall. So we can have an intramural hematoma that generally associated with a minimal bleeding. Also, I learned again that an IFOP is a good test, but only focus on the microscopic bleeding, and that can distract us from a macroscopic bleeding, but again can be intra or retroperitoneal and causing a paralytic ileus. We concentrated on the medications of warfarin, and Rabih again reminded us that can lead to both a hypercoagulable state and hypocoagulable state, meaning there can be ischemia associated, the side effect, as well as an increased risk for bleeding. Lastly, we got a bowel wall thickening on the CT scan, and then we tried to organize what are the what clues do we have and what can be the causes of that. So we can think about inflammation like an IBD, infection like an diverticulitis, ischemia, angioedema, or a malignancy or an intramural hematoma. My main takeaway point here was actually that I would have forgotten to ask for ACE inhibitor because that can also cause angioedema in the bowel wall. So we closed up with the final diagnosis of SBO secondary to intramural hematoma. So that was very a kind of twist in the case and shows us that the small bowels might be a little bit more vulnerable than the big bowel. So I've learned a lot. I enjoyed it. Thank you so much, everyone. And hopefully see you tomorrow.
I think your teaching has always been so spot on and so accurate, but the organization and the distilling it into these discrete chapters of your story, it makes it even more memorable. Thank you, Julia. That was awesome. All right, guys, I hope you have a fantastic rest of your day, and I hope to see some of you tomorrow for RLR on Friday. Bye, guys.